The intersection of endurance sport, health, fitness, and life. Challenging conventional ideas and empowering people with the science of self-propelled motion. This is the Endurance Experience Podcast, hosted by Tony Rich.
The website runrepeat.com released this summer what they claim to be the first mapping of global running participation. The analysis covers 108 million race results from more than 70,000 events from the period 1986 through 2018. They claim that it's by far the largest study of race results in history. They have demographic information in here, trends, pace breakdowns by sex. They have finishing time trends and much more. You'll find it very informative, as I have. I'll put the link to this in the show notes. But what I wanted to highlight from this data is the 2018 numbers, and it shows the participation of runners in the events. And what it shows is, above all, people are running 5Ks and half marathons more than anything else. The numbers from 5Ks were 2.9 million. So that means 2.9 million participants in 2018 in 5Ks. For half marathons, there were 2.1 million participants globally in half marathons. It's a lot of people running. Now compare that to 10Ks and marathons. Globally in 2018, there were 1.8 million participants in 10Ks, and there were 1.1 million participants in marathons. So, and then you look at the trends. The trends are pretty strong, especially for 10Ks and marathons. So needless to say, we're still running, and that's a good thing. It's a pretty phenomenal thing we do as humans. By the millions, we're training to start at some line and run to some other line as fast as we can. It's the purest form of self-propelled motion, and I've said this before, in my opinion, running is the most efficient form of getting and staying fit. And I think I can pretty solidly back this empirically. And I'm willing to stand and challenge that with anyone. If you're interested on the evolution of running, you go back and listen to the podcast with Professor Daniel Lieberman. If you haven't listened to that one, I highly recommend it. But when you're running, you're stringing together a series of controlled jumps and falls, which is exactly what running is. You're literally jumping and falling from one foot to the other, one leg to the other. And how that came about, we talk about in the Lieberman podcast. But when you hit the ground at 4 to 5 times your body weight. So running injury is something that you're going to contend with sooner or later if you run consistently. So this podcast is going to be about running, musculoskeletal injury, treatment, and prevention. Throughout training and racing endeavors, runners may run into lower extremity issues. This may especially be the case with marathoners and Ironman triathletes that put in so much running volume. And so I have a conversation with Dr. Caleb Johnson. He has a PhD from the University of Pittsburgh with a focus on rehabilitative science. And he also has a master's from the University of Pittsburgh in kinesiology and exercise science. I'll let him give his background in his words. You'll hear that in the podcast. But Dr. Johnson is part of a distinguished research team at the Spaulding National Running Center, which is one of the premier centers in the U.S. devoted exclusively to the diagnosis, treatment, and prevention of running injuries for runners of all ages and abilities. Spaulding provides evidence-based clinical care developed from 25 years of research. So I speak with Dr. Johnson about common myths that running is quote-unquote bad for you for the long term, or some people who proclaim that they are quote-unquote not meant to run, or they don't have the body to run, etc. You've heard those before. And then we go into interesting research behind foot striking and biomechanics. We talk about running injury and what the evidence says about the cause of some of the top running injuries. Then we get into treatments, and I get Dr. Johnson's take on the litany of treatments that are commonly marketed to runners, and all of these treatments that make extraordinary claims to help them heal and recover faster. And in this same vein, I get his take on alternative medicine treatments that are making similar extraordinary claims. So, without further delay, I will give you Dr. Caleb Johnson. I'm here with Dr. Caleb Johnson. Thanks for coming on the podcast.
Yeah, thank you for having me.
All right. So this is the podcast all about musculoskeletal injury, risk and prevention in runners. And before we start, I wanted to get our listeners familiarize our listeners with your background, your education, and your career. And I was always curious on why someone like yourself decides to make this your life's work. Were you an athlete and you decided that you wanted to get more involved with helping others? So let's spend some time there, just, your background, your education, and why you decide to work in this field.
Sure, yeah, absolutely. So I did my undergraduate in kinesiology at Penn State University. And then for my graduate work, both my master's and PhD, I moved to the University of Pittsburgh. Mm-hmm. I did my PhD in rehabilitation science. A lot of my research during that time was with Dr. Chris Conaboy, my advisor, and we focused on musculoskeletal injuries in the armed forces, which are a big problem for a lot of the branches of the armed forces. And specifically, we worked with a lot of most of the groups actually under Special Operations Command, so the Special Forces guys. Mm-hmm. And then also along with that, a lot of our work was in perceptual motor control, which is essentially how our perceptual and movement systems interact to control movement during athletic activities, or at least our focus was on athletic activities. Mm-hmm. Yeah, that was kind of my background. I finished up my PhD this past summer and was really fortunate to have the opportunity to come and do a postdoctoral fellowship with Dr. Irene Davis here at the Spaulding National Running Center, located at Harvard University. And so that's where I'm at now.
Excellent. And the Spaulding National Running Center, just for people who don't know, is, I'll let you describe. But describe to our listeners how the Spaulding National Running Center differs from, your conventional, physical therapy practice.
Yeah, absolutely. I guess the most basic way is that we specialize in the treatment of runners. And another kind of very unique aspect is it's an integrated center including a running clinic and a research laboratory. So I obviously work mostly in the research end of things, but we kind of have the full spectrum of treating runners and then also studying kind of risk factors for injury or treatment modalities to help runners return from injury, and integrating those, the spectrum of looking at those factors all the way through implementing them in the clinic.
Mm-hmm. Yeah, excellent. Yeah, it's a great facility. It's one of the facilities that I generally recommend with coaching athletes.
Awesome.
Yeah. It's and then Irene Davis is very well known and has a myriad of a broad research agenda in musculoskeletal injury, risk prevention, and her work is well known. Excellent. So I'll put the link to the Spaulding National Running Center into the show notes.
Great, thank you. That'd be great.
Yeah. So let's talk about so when you go onto the website and you read some of your approaches and philosophies, you talk about the evidence-based approach when advising runners. And can you talk about that? Your primary philosophy and approach that you take, because I think that really sets the tone for just everything, all the conversation points that we're going to hit.
Yeah, sure. I think I would say that is kind of the general mission of the whole Spaulding National Running Center. Mm-hmm. So again, it's the clinic, which includes a medical and a physical therapy clinic, and then our research laboratory. And we like to integrate the work of those two different parts of the center together. Mm-hmm. So things that findings we have in the laboratory, we use those to help our clinician team inform on the treatment of runners. And then a lot of the studies that are initiated down the lab come from things that our clinicians see up in the clinic. And again, I guess from that aspect, that's really where the evidence-based approach comes from. And then mm-hmm. obviously, Irene's just years of experience,
right?
Both treating and studying runners. She has an amazing kind of background in that, obviously, but most of the running community is familiar with her work.
Right.
I would just highlight a couple other people that our clinician team are the ones that are kind of involved with the day-to-day treatment of runners. So our medical clinic is run by Dr. Adam Temforty, who is an MD and then also a researcher specializing in bone stress injuries in runners, and also other athlete populations. And it's not really related, but he's also a very accomplished runner as well. Surprising, yeah.
I'm very familiar. I've never met him, but very familiar with him and his running career.
Yeah. And then our physical therapy clinic is led by 3 physical therapists: Lindsay Wasserman, Gabby Gostigan, and Josh Pulsick. And so they're a pretty amazing team. Mm-hmm. And getting the opportunity to be involved with them has been a great opportunity as well here.
All right, got it. And so you're evidence-based. That means you everything that you do is based within epidemiological study, science. You're looking at what does the preponderance of evidence look at or suggest when treating and preventing injury and such.
Yes, and I think a key aspect of that is there's a saying, I guess, it's paralysis by a lack of information. Mm-hmm. So a lot of times you're kind of working with the best available evidence that you have, and as a researcher, you have the luxury of being able to say that, I don't really know about this, but as a clinician, as someone who's actively treating runners, you have to make a decision one way or the other, right?
Mm-hmm. Right.
So a lot of the things are, using the best evidence that's available and kind of making a judgment on what you think is
the
right treatment.
It's very important because, especially when you talk to runners and triathletes, short course, long course, everyone has an idea about what works, and they sort of go to the Google doctor or the social media doctor when things happen. And sometimes I see some of the things people are saying. I mean, I don't have the energy to be in the comment sections, but I look at some of the things that people are saying, and I said, my goodness, it's unbelievable what happens. So
sure.
People like you and your team at Spaulding are definitely needed.
Oh, thank you. Yeah.
So let's go into just talking about running. And so we have accomplished runners. We have people on a spectrum from recreational to professional. But oftentimes you'll hear people say, I'm not meant to run. I don't have the body for that. Or, people will say that running is bad for you long term. It's going to destroy your knees in the long term. So what is your core philosophy on that, and what would you say to those folks?
Yeah, it's a really good question, and the answer is a little tricky. It's one of those half one way, half the other kind of things. I think what most people are referring to, or at least you hear that also in the research community, along the lines of that the number one risk factor for a musculoskeletal injury related to running is running, right? So you can have all the other risk factors. You can have high body fat, low bone density, poor running mechanics, misaligned bone morphology, and all the other things that we think are related to injury. But if you don't run at all, you'll never suffer a running-related injury, right?
Right.
But I guess my sort of philosophy, and I don't want to step on the toes of, anthropologists and evolutionary biologists that are a lot smarter than I am. But I don't think there's much argument among those fields that humans as a species are well equipped to run. In fact, I think it's sort of the opposite. Most of them agree that humans evolved to be one of the most efficient species in the animal kingdom at moving over ground because of running. Efficient meaning being able to maintain the highest speeds for the longest period of time, not necessarily just run the fastest. So I think maybe the question that people are, or I guess the idea that people are getting to is whether modern humans with the occupations of an advanced society are well equipped to run, without any guidance on mechanics or their progression and training load. And there's a number of things that play into that, whether someone can just go out and start running at some point in their life and remain injury-free, which, is the main focus of our work here. But I think at a fundamental morphological and biological level, I do think the human body is equipped to run. And I think kind of that one part of your question, about, you hear people say sometimes that running is, it might be okay for you short term, but long term it's bad for you. And I disagree with that. And I think that kind of highlights the idea that the body at a basic level is equipped to run. So there's a lot of evidence, even though we know that running is associated with a relatively high rate of musculoskeletal injury acutely, habitual runners are not at a higher risk for chronic or degenerative musculoskeletal conditions later in life. There's a lot of evidence showing that compared to a normal population, and even maybe more notably compared to other athletic populations, they're probably at a lower risk of those sort of conditions, things like osteoarthritis. So I think that combined with all the other health benefits of running can't really lead you to conclude that running is bad for you long term overall. And again, just kind of, I think it's more, we need to focus on figuring out how to get people running the right way and at the right level to avoid sort of the short-term setbacks of having injuries. I guess that's my long-winded answer.
Yeah, no, that's great. I think I'm letting you go on because I'm saying, he's He's saying everything that I've known. So we've had Daniel Lieberman. I know you know who that is.
Yes,
Daniel,
absolutely.
We did a podcast with him, and we talked about his book. And, obviously he'd echoed many the sentiments that you just gave.
Yeah, a lot of that work I was referencing is definitely his.
Yeah.
So all credit to him, not to me.
Yeah. And, you're looking at, the net benefit, so with running being one of the most efficient ways you can burn calories, the most easiest from an accessibility standpoint, anybody can just grab some sneakers and just go out and run per unit of time. And so the net benefits over the long term are immense. And it's unfortunate because a lot of the bad information is really, unfortunately, coming from so-called fitness professionals out there, right? So there's a little battle coming from the personal trainer and strength and conditioning types and the endurance enthusiast types, where there's sort of like a tug of war for the athletes. Everyone's on one side saying, no, don't run, you should do X.
Yeah.
And on the other side, they're saying, oh, yeah, you should run, swim, bike. And so, but, I think people that understand the benefits of running understand that, that over the long term, the net benefits are, pretty solidly founded. And, from a standpoint of just combining different activities with running, I think the diversity in your fitness approach is going to be important as well.
Right. Yeah. I mean, that's the point, right? It doesn't have to be one or the other.
Right.
We would obviously still advocate for other types of physical activity. But, running is, like you said, one of the most accessible and easiest ones to participate in.
Right.
And I just think the overwhelming feeling that people get from running, which is evident with, its rise in popularity, you can't really replace that. And if it's an activity that can get that many people active, and make them able to enjoy all the benefits of being physically active,
right.
It's obviously something we should promote and focus more on figuring out how to get people to run healthy, not, I guess the opposite, which is just trying to get them to stop.
Mm-hmm. Right. Excellent. So, obviously, you see a lot of runners. What are some of the common biomechanical issues that you see in runners that tend to signal some form of necessary corrective measures in some part of their body, some imbalance, or some other issue? Yeah,
absolutely. So I would start out by saying that they're obviously the biomechanical issues are very injury dependent. So that the mechanics that underlie a given musculoskeletal injury are always going to be really different. But there are some kind of universal ones that are related to a number of common running related injuries. So I can highlight some of those in the interest of time, I guess.
Yeah.
To just go over those. The first two are basically just alignment of the lower extremities, and in what we call the frontal plane. So looking at the body from if someone's facing you. So the first one is hip adduction and internal rotation, which are a little bit different. But when you're kind of just visually determining these by watching somebody run, it's hard to pick out internal rotation of the hip from adduction. So we can kind of think about them together. So that's essentially just the position of your knee relative to your hip when you're looking at somebody from the front. And a knee more or closer to the midline of the body is going to be a more abducted hip, and the knee closer to the outside of the body is going to be a more abducted hip. So having a higher having your knee closer to the midline of your body has been shown to be related to things like patellofemoral pain, iliotibial band syndrome, and to a lesser degree, tibial bone stress injuries. So one of the things that we think really helps control that is activation of the gluteal muscles, specifically prior to landing, prior to foot strike with each stride. So that's a good one because it's related to a couple. The other one is at the ankle. So foot ankle or foot eversion, or a lot of times it's referred to as pronation. Again, they're a little bit different, but they're essentially looking at the same thing visually anyway. So that's looking at your ankle, and if your foot is turned more out towards the outside of the body, that would be an increase in foot eversion or pronation. And through stance, that has been related to a number of injuries again, Achilles tendinopathy, patellar tendinopathy, and potentially plantar fasciitis, which are all very common in runners. So those are kind of the two alignment ones, and we say that, the lower extremities in alignment. So if your knee is lined up with your hip, your foot is relatively lined up underneath your ankle, you're most likely going to be at a much lower risk of injury.
Right.
So
Okay. I've seen some of those things that you described in many runners, particularly one where you described that someone's foot sort of kicks out. I call it the egg beater, where they sort of they sort of kick out instead of going backwards. And I always think, how did that happen? How did that learned behavior get ingrained? And what I've also found that people who have played some form of ball sport generally have pretty good running form, I noticed. And
interesting.
Yeah, it's maybe it's because of running after a ball, playing, running after trying to catch a defender, or run away from a defender, trying to defend and catch up to someone, or running under a ball trying to catch it. And it's almost like they've years playing some ball sport, they've adapted to the biomechanics that are necessary to either catch the ball or catch the defender. But I definitely see a lot of what you described, that sort of the egg beater type of gait.
That one's a little tricky because in general people tend to land with their ankle turned in a little bit at first strike, and then they tend to move through eversion as they're pushing off. And so a normal amount of that is healthy. It's actually a way of dissipating the forces, and so not letting them travel up to other structures in the lower extremities. It's the excessive amount of it that it's kind of like one of those things where at a certain threshold it starts to place abnormal forces on you can tell from the injuries, Achilles tendinopathy, plantar fasciitis, on the structures at or around the foot. So that's it is a tricky one.
And so somebody comes to you and you see these asymmetries when they're running. How do you assess someone to figure out, I'm going to try to change the way this person runs, versus, I'm going to let that go because, it might be more trouble than it's worth to try to change that? Or do you always try to change or improve the runner's biomechanics, no matter how severe the asymmetry is? That's so. I'll say that I can give my 2 cents, but again, I'm not involved in the treatment of runners, so I don't want to, pretend like I kind of do this for a living, like some other more qualified people do. I think the one important thing is that if a runner is a seasoned runner who has never been injured, if we do an assessment and we see something that we think
might be related to poor mechanics. You're never going to try to change something in a runner who isn't injured, right?
Mm-hmm.
And anytime you change any aspect of any movement pattern, more or less running, you're essentially just changing how the loads are distributed throughout the body during that movement pattern.
Mm-hmm.
So you run the risk of taking an otherwise healthy runner, changing something, and then ending up just switching where the loads are being absorbed throughout the body and causing different injuries, or causing a injury, I guess, in that case, in the first place.
Right.
I think for so that kind of doesn't apply to us, because almost every runner that comes to our clinic does have an injury. So
right.
we use a pretty detailed assessment at their kind of their first session with us. They come down to the lab and they see one of either me or one of the other lab members. We do a gait assessment on our instrumented treadmill. We get an idea of their ground reaction forces, their loading patterns while they're running. We take a lot of video, high-speed video, so that we can slow it down and kind of see exactly what the different parts of their lower body are doing while they're running. And then they go upstairs with Dr. Davis and another physical therapist and do a pretty extensive assessment, testing everything from flexibility to functional movement patterns to
mm-hmm.
strength. And then, based on all of that information, the clinician team kind of comes up with a plan for them. And obviously, where their pain is and what kind of injury history they have as well. So yeah, I guess it's not a very good specific answer, but in general, that's kind of our approach to thinking about what mechanical things we can change.
No, that's great. That's the thorough approach that you would expect. And I mean, I can imagine that, because if I come to you and I have plantar fasciitis, say,
Mm-hmm.
And you want to you're trying to find the root of that, or potentially find out why that might be occurring, versus just trying to change something.
Yeah. Yes. Yeah. Absolutely. Yeah. So, getting a good idea of the underlying mechanics that are potentially, creating that injury. That's essentially our approach to it.
Mm-hmm.
The big piece, I guess, I would mention that I'm leaving out there. So our focus in the lab is biomechanics. Another big piece of overuse injuries that runners typically have is different training parameters. So the total mileage they're completing, the intensity they're completing that mileage at, the progression of that mileage if they're just starting out running. All of those things also play in. So you can have someone who has flawless mechanics, but they're just progressing in their mileage too quickly, and that's what's causing some sort of inflammation or pain.
Right.
So those are all things that they consider at the clinic as well when they're kind of retraining gait patterns that they think might be related. They do it in a very slow, progressive manner. They control the mileage of our patients. While they're kind of ingraining those new patterns that we want them to have. And I think that's a really big part of just, injury risk in general, that sometimes in the biomechanical community we try to gloss over because it's not really our focus. But
mm-hmm.
I would say it's equally as important, if not potentially more. I'm not sure we really know what the exact percentage of importance is for each of those two factors.
You bring up a good point, because as coaches, we'll maybe we'll have an athlete that is training for a half marathon,
mm-hmm.
Short course, long course, triathlon, and oftentimes they'll be in a build phase, maybe they're in the peak volume phase, maybe they're 8 weeks out to an event, and they'll see some form of lower extremity issue, and the reason why I prefer institutions like yours versus a conventional practice is because the conventional practice may sometimes, if they don't have a serious end-to-end protocol for runners, they may just not realize that the issue might be coming from overuse versus some musculoskeletal issue.
Yeah.
And and so I'll have a mutual client with a physical therapist who might say, completely, maybe their recommendation might be just to stop activity, or take some corrective measures. But someone or a practice that might be more familiar with runners and macro cycles, training cycles, and base phase, build phase, peak phase.
Right.
And they may just recognize, okay, you have an overuse issue that's a direct result of the volume that you're placing on your muscles, and that maybe the approach is a little different there.
Yeah, absolutely. And I think, again, there's almost always some mechanical component, because if you're usually there's some aspect of their mechanics that is placing a load on a tissue that it's not used to experiencing, right? But again, if they didn't run at all, then they wouldn't ever develop into an overuse injury.
Mm-hmm.
And it can be less of a mechanical issue, and still, if your training volume is too high, or progression in your training volume is too high, eventually it most likely will result in an injury as well. I totally agree.
Mm-hmm.
It's a very important aspect.
Wearable technology. Is there any new venues of technology that you think might help runners here?
Yeah. I think I'd say currently we're still kind of working on the exact kind of, I guess, metrics you want to track related to training volume, because you can think of your training load in terms of just mileage, but if you include a measure of the actual impact or the loading that the lower extremity is receiving during each step in that mileage, you get a better kind of estimate of the overall load being placed on the lower extremities during each given bout of running. So some of those metrics, I think we're at a pretty good point now where we're starting to figure them out, and figure out how to use them. The next step is really moving those into the field and verifying that those are really important when you do track runners during real-time training bouts. And that's actually moving forward is something that we're looking at, kind of developing some studies for at the lab.
Got it.
Something we're very interested in.
Yeah, interesting. Okay, so I meant to ask you. You had mentioned pronation. What are the elements that you look at with foot strike? Do you look at pronation at all? Do you look at forefoot strike versus heel strike?
Yeah. That was actually one factor I didn't mention. I did have a note written down about it for that question. I just it was on another page.
Yeah.
So pronation is definitely something we look at foot strike. It's also important to look at it through the stance, right? Because again, a lot of runners land with inversion, but then by the time they're pushing off, they're at an excessive amount of pronation, and that kind of signals poor control of the ankle musculature. Again, a normal amount of pronation is healthy to help dissipate the forces, but an excessive amount indicates potential, kind of interventions for increasing foot muscle activation and calf muscle activation to help control that motion more. For forefoot versus rear foot, so we do look at that. That is one of kind of our focuses, and our general recommendation is that we promote a forefoot strike pattern,
right?
Because we know this on average overall, it results in decreased rates of loading. But we are kind of, a lot of the more recent work that's coming out, not just from our lab, from other labs, is starting to kind of get away from categorizing people as just rear foot or forefoot, because the impact phase when your foot's just striking the ground and you're getting those high rates of loading in the lower extremities is longer than just when the foot strikes that initial moment. And there's some aspects of mechanics that kind of separate out whether or not having a rear foot strike pattern will actually result in overall higher rates of impact loading.
Mm-hmm. Got it.
So let me actually, that was a bad explanation. I do have, so essentially what we've looked at a little bit and what some other people have is that there's, if we separate people by rear foot and forefoot, they generally, rear foot strikers have higher rates of loading, but there are rear foot strikers who have very low rates of loading, right? So what we're interested in is what are those people doing that they're running with a rear foot strike, but they don't have these typical high rates of loading.
Mm-hmm.
And two of the things that we think are actually striking with a higher foot strike angle, so with the toe pointed more towards the air at foot strike, and then also with a more extended lower leg. And both of those, we think, increase the time over which those forces are applied to the lower extremities, which then will result in a decreased rate of loading.
Right. Yeah, and for the listeners, forefoot means ball of foot, effectively,
yes.
Right? Yeah.
Yeah.
And so there's been a lot of research about landing on your heel, and there was some controversy about why that is. Many people thought it was because of the sneakers and the extra padding, right? That's in the back of sneakers, and that promoted people to land on the heel.
Yep.
So and this is one of the things that I see in runners all the time, and you know that I've seen the same research that you're describing about forefoot strike, and so oftentimes if you're coaching an athlete, it's hard to try to change anybody regardless of what they're doing, because like you said, you could try to change something and break something else. And so
I think that brings up another good kind of caveat to that, is that that the idea with forefoot striking, reducing kind of overall risk for injury doesn't factor in performance at all. So for your athletes, there is some good evidence that suggests that forefoot striking might result in lower overall running economy or running efficiency during long distances. They think it's due to the increased activation of the lower leg musculature that forefoot running demands, and that just leads to overall energy utilization, and then a lower efficiency at a set running intensity. So some of that research is mostly just looking at acute changes in strike pattern. So not necessarily people who are habitual forefoot strikers versus people who are habitual rear foot strikers, because there's a very small proportion of runners who actually are habitual forefoot strikers. And so change, it might be that when you look at these two groups, if you get people who are used to forefoot striking and whose musculature has developed to kind of allow that, that their efficiency would be, equal to rear foot strikers overall. But, changing anything acutely will almost always decrease your running economy in the short term. So,
yeah,
but just something to keep in mind,
Interesting. So, when you see people that have some musculoskeletal injury, what would you say, runners particularly, what would you say are the top, 3 to 5 issues that you see? You mentioned some. Yeah.
So there was a really nice review study by Peter Francis's group. He's out of the UK recently. And it kind of marries with some of the former reviews on just the general distribution of injuries in runners. So the top 5 are usually thought to be patellofemoral pain, medial tibial stress syndrome, Achilles tendinopathy or tendinitis, plantar fasciitis, and iliotibial vein syndrome. And I would say that's pretty typical of what we see as well. So, yeah.
Yeah. And all of those could either point to some musculoskeletal issue, imbalance, or overuse, or both. Yeah.
I would. Our favorite saying in, the musculoskeletal research world is that all injuries are multifactorial, and then we just say that, and then we don't actually have to put a stake in the ground for any one given factor. But yeah, in terms of just overload or overuse injuries in general, they all kind of result from too many cycles of loading, placed in the wrong places, and then inadequate time in between cycles of loading to allow for tissue healing or remodeling. That's kind of the general model of injury for all of those.
Got it. Yeah, I think at one point or another, I've had everyone that you just described. I think everyone listening could probably say the same. If you've gone through several cycles of marathon training or Ironman training, you probably have faced them more than once.
Yeah. I would be curious if you work with a lot of triathletes. Do you, in more cyclist athletes, what kind of injuries do you see in those individuals? Yeah,
it's funny because most of the time it's running related. Very infrequently will you see a swimmer or a triathlete that has a shoulder injury, say.
Gotcha. Okay.
You never really see that. It's probably because triathletes don't really swim a lot. They neglect that one, but that's another story. But in cyclists, I don't see a significant amount of injuries related to cycling. It's almost always, well over 2/3 of the time, a running-related injury. And it's because of, the impact stress placed. Oftentimes someone will get injured running, so we'll say, "Oh, I guess you're going to go ramp up your swimming to try to, do some no weight bearing act." Cycling or trying to just take the weight off their lower extremities, but it's almost always a running injury that would cause us to take volume off the table or go into a recovery cycle or something like that. Closing in on some of the final questions. The common, and maybe you're the best one. Maybe it's one of your colleagues that's more experienced here. But does the common RICE or rest ice compression elevation, massage, kinesiotape, any of this stuff have any efficacy for musculoskeletal risk minimization, prevention, or anything like that? Every time you turn around, you see a manufacturer selling some device on social media, making the claim that buy my device and then this will make you injury free or recover you faster, heal you faster, and such. Do you have any dog in this hunt?
I see them all at conferences too. We get all of those. I'm not super familiar with this area, but I can give you my 2 cents. Related to RICE, kind of in general, rest ice compression elevation, it's all about limiting inflammation. And I at least know the 2 kind of sides to that sort of, I guess, debate. So originally it was the recommendation for any musculoskeletal injury, right? You wanted to limit the inflammation and to help speed up the healing process, and also just to help functionally people get back to doing whatever they're doing quicker, because inflammation hurts. And the newer kind of thought is that the inflammatory process is a healthy and normal kind of process, and it serves a number of important functions related to musculoskeletal health. So it's how muscles are remodeled and how you improve strength after resistance exercise. That's all an inflammatory process. It's how when you injure a ligament, a tendon, a muscle, that's how the macrophages and all the other things, that's how they navigate to that site and heal you eventually. So a lot of people think that kind of inhibiting that process is inhibiting the natural healing process or other processes that are important for musculoskeletal health. So I guess my kind of 2 cents is it really comes down to the individual. Mm-hmm. So for proper healing, it might be beneficial to allow the inflammatory process to just take its natural course. But if you're an athlete who has to compete or train tomorrow, or if you're somebody with an active occupation who has to be able to move around at work and lift things and, walk places, limiting inflammation is probably a good thing. Mm-hmm. If you sprain your ankle, if you're running and your kind of knee swells up from running, you could let it stay inflamed and potentially let it heal better. But it's not going to help you in the morning when you have to get up for work, or if you're an athlete when you have to get up for training. And I think based on our current level of evidence, a lot of the RICE kind of what limiting, or just in general limiting inflammation, is focused on limiting excessive inflammation. So you're never going to stop the process completely, right? And so I think it's probably beneficial for, in logical terms, for normal everyday function and healing.
Yeah, on the one hand, like you said, right, so we put athletes through this cycle, and it all depends on recreational, competitive, professional, whatever, but right. we want to put them through a cycle of stress, sometimes overload, and then recovery, and then the body responds by adapt, and then we do the cycle all over again: stress, overload, recovery, adapt, stress, overload, recovery. And then so ideally, oftentimes, like you said, we want the inflammation so the body can respond by building itself up stronger. Right. And so sometimes, especially if you're competitive, you actually don't want to minimize the inflammation too much. Yeah. But you're right. Someone who might be a recreational athlete and has a 9-to-5 job, they have a different goal there. But I think I wanted to get someone like you, knowledgeable like you, so as to try to curb the increasing decision-making process where athletes are looking for a silver bullet that is going to, some tape that's going to solve their problems. That
one I can definitely give you a definitive answer.
What is that?
The kinesio tape. Yeah. There's a lot of literature on that, and in terms of kind of promoting joint stability, or if you think of the other common tape jobs that athletes get, it's all to limit joint range of motion to essentially help your joints stay within a healthy range of motion and limit the risk for injury. It certainly has no effect.
Right.
In terms of improving, the one thing that I think it has been shown to do is improve blood flow to the area that you apply it over. So it kind of helps stretch out the blood vessels and promote blood flow, which I guess could have an important benefit for the healing process and pain relief. But I'm not really sure that there's any evidence to show that it does, really.
Right.
Because, again, it beyond the normal inflammation that you get that promotes that healing process, I'm not sure that more blood flow is required, essentially.
Right. Yeah. And I saw some of that too, and I think one of those brands are actually in the midst of a class action suit. And it's amazing what's being sold. I keep seeing this reoccurring. Some manufacturers selling basically a drill. It's a drill with a drill bit, a circular drill bit on it, and the people are just sort of drilling muscles and various forms of massage. And
That's interesting.
It's what they're doing is they're tapping into this desire for the silver bullet,
right?
And it's I'm constantly pushing back on it,
Yeah.
and so on that vein, I wanted to get your thoughts about alternative medicine. So you had mentioned that you're evidence based and you focus mainly on medicine. And so oftentimes runners will take practice into alternative medicine, dry needling, acupuncture, things like this, cupping, as a means to try to heal or treat musculoskeletal injury. Is there any thoughts on that? What are your...
Yeah, again, I'm certainly not an expert in this area, or the most well-read. I think for some of those modalities, there is some good evidence that they do something at least. I think dry needling in managing kind of musculoskeletal pain, it has some efficacy. Cupping, I know, again, it's the main idea there is to promote blood flow to a certain area and help with the healing process. I mean, I think even in terms of, dry needling with helping to limit pain, and then, ideally for an athlete that would help them get back to training quicker. I would be skeptical as to how much of that is just related to a placebo effect, because I'm not really sure of any work that has addressed the actual mechanism by which it reduces pain. But I know, I guess, from a practical standpoint, at the end of the day, pain is a subjective phenomenon. So if it makes someone feel like they're better able to train and function the next day, and there's no real safety concerns with it, which I don't think there is for dry needling, at least, I wouldn't be opposed to it. Obviously, it can also come down to kind of like a cost benefit kind of thing, where I don't know if you're pouring tons of money into that, if it's going to have any real benefit for your money. But yeah.
Right. Now, but does Spaulding wade in these waters, or?
We don't, not at our center anyway. I know the Spaulding Rehabilitation Hospitals, I believe, have an acupuncturist on staff. I believe they may use cupping it in some of their physical therapy centers. I don't want to be a spokesperson for them. I'm not positive on that. But if they do, they're probably obviously certified to use all those modalities. So, yeah.
Interesting. And, we're seeing physical therapy practices. It's about 50-50, I think, the conventional physical therapy practices. I know some who wade in those waters, and I know some who don't. I think sometimes they do, because, like you said, if some people have taken the stance that, hey, if it's a placebo effect only, great, we'll take it, and obviously it will make money. I think as a coach who's evidence based, I think the lack of empirical evidence is to me is what's troubling, and
I understand,
and the fact that it's not really regulated, and right. So, so I think, like you said, I think when you have an end-to-end approach that's evidence-based, and you have a way that you can take video, you can analyze gaits, things that are based in epidemiological study. These are the things that ultimately is going to be more helpful to runners, I think.
Oh yeah, and just to be clear, I don't think any of those modalities have any real function in the treatment process of an actual injury. I see them more as kind of supplementing things that athletes are doing for recovery from training bouts. But in terms of preventing musculoskeletal injury or treating musculoskeletal injury, I don't think there's almost any evidence to suggest that they would have a real effect for either of those. So
right. And you also look at people like yourself. If I were to tell you right now that I have some lower extremity issue, what do you think it is? What you see is a substantial amount of caution, so as to not give out bad information or misdiagnose. Come on into the clinic, we'll take a look at you, we'll do this and that and the other thing, and a lot of caution and care. Whereas the practitioner of alternative medicine will tell you right off the bat that they have a cure.
Yeah, absolutely.
And
yeah.
This is the part that's troubling. Where
it's more selling something than deciding what the best treatment is.
Right, and that's the challenge with some of this, and so great. So anything else that you can say? Any final words of advice that you can give runners?
I think we touched on a lot of them.
Yeah.
I had some things written down just in case we didn't get to them.
Go for it.
I had, just kind of, again, our focus is on kind of biomechanical factors. But obviously training parameters play a huge role in limiting injury risk. So I just wanted to emphasize that again, that, I'll usually talk about the biomechanical factors, but there's a whole other kind of part that we have to keep in mind. And then just, I guess, one caveat would be the last thing is that a lot of the literature that is out there in general, but especially the stuff we focus on because it's the population we see most often is focused on recreational runners, not necessarily competitive or high-level endurance runners. Just from a public health perspective, that's kind of the population that has the largest opportunity for impact, obviously, in limiting musculoskeletal injury and helping people stay active. So that is kind of our focus, but there are obviously some differences between recreational and competitive runners in terms of both their goals or objectives, like we sort of talked about a little bit, as well as their body types, fitness levels, musculoskeletal structures. And so those are all likely to change their risk factors for injury. So, it's just a kind of an important thing to keep in mind with all the things that I mentioned.
Excellent. Now, if someone wants to get in touch with you, runners, triathletes, they want to get in touch with you, they want to get in touch with Spaulding for help, how do they reach out to you and or Spaulding? Yeah,
absolutely. For me, they can reach out to me. My email here is C as in cat, D as in dog, Johnson @partners.org. For getting in touch with the center, if they're seeking treatment, I would say the best way is if you're going to post the website. That's probably the best way. There's a lot of information on there about how to get into contact with the center and get set up with an appointment to come in and see us if they want to.
All right. The Spaulding National Running Center, Dr. Caleb Johnson, thank you for coming on to the podcast.
Yeah, thank you so much again for having me. I really appreciate it. It was fun.
Thank you to Dr. Caleb Johnson, and I highly recommend checking out the Spaulding National Running Center if you're in the United States in the Northeast and you have a running issue. You can go check them out. There were a couple of big lessons from this podcast for runners. I know many coaches can relate. Far too often we will have athletes or we'll run into an athlete who will have some lower extremity issue, some leg issue from running. They're in the training cycle. They got some event coming up. And unfortunately, many of those runners will seek out practitioners that make extraordinary claims to heal you with quote-unquote release techniques and other practices that basically just amount to various forms of intricate massage. And then there's the manufacturers that will sell you, the kinesio tapes or massage drills that will make claims to drill you into recovery or heal bone, ligament, tendon, muscle, fascia with tape and things like drills. I would approach all of these manufacturers and practitioners with extreme skepticism because they're not evidence-based. And I know there are some smaller percentages of physical therapy practices that have jumped on offering alternative medicine in their service offering. Acupuncture and dry needling, which is basically a refried version of acupuncture, cupping, and some others. However, I think it's pretty telling that practices that hold themselves out as evidence-based practices don't wade in these waters. Alternative medicine that's backed by empirical evidence has a name. It's called medicine. Think about it. If any of that stuff worked or had any efficacy at all, then it would just be subsumed into medicine. It would become medicine. And it would be used by any practice that uses evidence-based approaches. For running, musculoskeletal injury prevention and treatment, you should go to a physician, a doctor, a qualified sports medicine practice. And these are the doctors that are going to go through medical protocol in order to help treat, heal, prevent, etc.
Follow Event Horizon Endurance Sport on Facebook, Instagram and Twitter for training programs and services. To become a member of our Endurance Institute or for a complete archive of podcasts, log on to our website, eventhorizon.tv.